Hi everyone, I'm Dr. Rahil. Welcome to another learning session. Today we will discuss acute coronary syndrome, a case-based approach. Let's start with our first scenario. We have a 73 years old lady who was brought to the emergency department by ambulance. She complained of central chest pain, crushing in nature for past 3 hours. She has past history of hypertension and COPD, but no previous history of heart problems. She was hemodynamically stable on examination and there was no evidence of heart failure. Please pause the video to look at the ECG to answer the question on the next slide. What is the diagnosis here? Please pause the video to go through the options. The correct answer is option 1, which is inferior wall MI. Why this is correct answer? Let's discuss acute coronary syndrome in detail. Acute coronary syndrome or ACS is an umbrella term which refers to a spectrum of acute myocardial ischemia or infarction. It is divided into 3 categories: ST elevation MI, non-ST elevation MI, and unstable angina. This is based on the ECG changes and cardiac enzymes like troponin or creatinine kinase. We will learn about each condition in detail in the next few slides. Let's start with ST elevation myocardial infarction or STEMI. In STEMI, ECG shows persistent ST elevation in 2 or more anatomically contiguous leads. Cardiac enzymes like troponin would be significantly elevated, but we don't need to wait for the lab result to initiate the definitive treatment, as the diagnosis is based on the clinical symptoms and the ECG changes. In this slide, we can see the evolution of ECG changes in patients with acute ST elevation MI. This is normal ECG morphology. This is P wave, followed by PR segment, QRS complex, ST segment, and T wave. In the beginning, there may be hyperacute T waves. This is followed by ST segment elevation. ST segment elevation is measured from baseline, that is PR segment. 1 mm elevation equates to 1 small square on ECG. This is the PR segment and this is the ST segment elevation. In acute MI, QRS complexes merge with T waves. In patients with evolved MI, usually after 12 to 24 hours, Q waves develop and ST segment comes back to baseline. Initially, T waves are inverted, but eventually they become upright. We can localize the affected area of the heart according to the ECG changes. To be significant, there should be a ST segment elevation of 1 mm or more in inferior leads, which are 2, 3, and AVF, and 2 mm or more in chest leads V1 to V6. ST elevation in leads V1 to V6 correspond to anterior wall MI, whereas if it is confined to V1 to V4, it is anteroseptal MI. This territory is usually supplied by left anterior descending coronary artery. In lateral wall MI, ST elevation is seen in leads 1, AVL, V5, and V6, usually supplied by left circumflex artery. ST elevation in leads 2, 3, AVF is suggestive of inferior wall MI, usually supplied by right coronary artery. Let's look at this ECG again. Focusing on ST elevation, there are 3 to 4 mm ST elevations in leads 2, 3, and AVF, suggesting inferior wall MI. There is ST segment depression in leads 1 and AVL. These are reciprocal changes. There appears to be some ST elevation about 1 to 2 mm in chest leads, especially V1, V2, and V4. To be significant, it should be 2 or more mm ST elevation on contiguous chest leads. So currently, it does not meet the threshold of MI in anteroseptal leads. These unusual QRS complexes are ventricular ectopics. This is another example of acute inferior wall MI. there is about 3 to 4 millimeter ST segment elevation in leads 2, 3 and AVF. There is another significant finding on this ECG. Can you guess what it is? There is ST segment depression in leads V1 and V2. If there is ST segment depression in leads V1 to V4 with presence of R wave and upright T waves, it is diagnostic of posterior wall MI, which can be associated with inferior wall MI, as both areas are usually supplied by right coronary artery. This is the example of anteroseptal MI. Here we see ST segment elevation at least 2 to 3 millimeters in leads V1 to V3. Management of acute ST elevation MI consists of pain relief, dual antiplatelets, and definitive treatment, which can be either primary PCI or thrombolysis. Let's discuss about analgesia. Acute ST elevation MI is a very painful condition and pain relief should be utmost priority. It is achieved with morphine given intravenously and it is titrated according to severity of pain. Other medication is glyceryl trinitrate or GTN, which can be given sublingually or as an intravenous infusion. All patients should receive dual antiplatelet therapy, which include aspirin 300 mg and prasugrel 60 mg or ticagrelol 180 mg oral. Clopidogrel is an alternative if there is high risk of bleeding. Primary percutaneous coronary intervention, that is coronary angiography followed by stent insertion, is the gold standard for the management of acute ST elevation MI. If it cannot be performed within 2 hours of patient's arrival in hospital, thrombolysis should be given. Choice of thrombolytic agent depends on the individual hospital. In our trust, we use tenecteplase as a thrombolytic agent. Thank you for watching. I will discuss non-ST elevation MI and unstable angina in the part 2 of this presentation. Till next time, take care and goodbye.